So I just want to give you a brief outline of how I approach bifurcations. No conflict related to this topic at this point in time. So what do I consider? First of all, is it a true bifurcation, not a true bifurcation? If it's not a true bifurcation, generally speaking, crossover stenting will work, not 100% of the time, but it will, and that's provisional stenting is, after all, stenting with one stent unless it doesn't work, and then we put in the second stent, of course. How big is the side branch? Now, there are several aspects to this. What is the diameter of the side branch? Generally, we would want it to be at least 2.5 millimeters, minimum 2 millimeters to consider stenting. So the size is not just the diameter, but the length. And therefore, how much territory does the side branch subtend? Studies have shown that even though we may consider side branches to be small in terms of diameter, they're probably diffusely diseased if they're long. And that a side branch of 73 millimeters is known to subtend at least 10% of the myocardium, so an important side branch. Clearly that would be important. So related to this, is it in fact a left main bifurcation? If it's a left main true bifurcation, oftentimes we are going to be choosing a two-stent technique up front, not always. A very discrete stenosis at the ostium of the side branch does not necessarily mean that you need to put a stent in it, because a provisional approach with a nicely deployed main vessel stent with a distal recrossing and the scaffolding that you can achieve at the proximal edge of the side branch often works very well in a situation like that. Is it a left main bifurcation with a dominant left? If it's a dominant left, that it's even more critical and may require, in this setting of a true bifurcation, a two-stent procedure. So the territory we already discussed. Important, what is the LV function? These are often very complex lesions, and often, especially in the case of left main bifurcations, these patients have depressed left ventricular function, so there are several issues around that. Do you need mechanical support? Probably in a small minority of patients need mechanical support, but certainly, at least in these patients, in complex left main or non-left main lesions where a lot of territory is involved, I will often have a second sheath in situ so that in case things do go wrong, I can deploy a mechanical support device. In those situations with poor LV function, I virtually always put in a right heart catheter, and PA monitoring is essential, I think, to understand what else you need to do. If your LV EDP, if your right heart pressures are very high, I may at some point actually, in a patient who's not unstable at the point, refrain and delay the procedure until the patient is better hemodynamically optimized. So those are important considerations. And monitoring with a PA catheter during the procedure, which is often long, complex, is also important. The bifurcation angle is important in terms of what choice of modality. So for example, a very narrow angle bifurcation, if you are going to be choosing a provisional approach in an important bifurcation, what are the ramifications in case you need to deploy that side branch stent? In narrow angle bifurcations, especially with large side branches, I don't think that a tap technique is particularly ideal, because you will have a lot of protruding stent into the main vessel. So other techniques should be considered up front, such as DK crush. In the case of a non-true bifurcation, if things went awry in the side branch, I think something like a reverse crush is also not unreasonable, or a culotte technique. Lesion length, the Shaoling's group have recommended that two-stent bifurcation should clearly be utilized in patients who have side branch lesion length of 10 millimeters or greater. and that under 10 that's not necessary. I don't think that's necessarily always true, and there are many bifurcation with side branch lesion lengths that are otherwise complex, less than 10 millimeters, in which case the patients will still benefit from an upfront two-stent technique. So it is definitely an important consideration. If long, for sure, two-stent in a large branch especially, and if not, you still may need to use a two-stent technique. Will the side branch be difficult to access? So retroflexed side branch, or one that we think if we stent over it, we're going to have a lot of difficulty accessing, that should be treated with two stents up front, in my view, if it's an important side branch. Calcium is always important. We've heard a lot over this meeting about calcium modification. Yesterday, I think we had a couple of sessions on this with many lectures. You need to have all the tools necessary to deal with calcium if you're going to undertake these procedures. Otherwise, things may go awry and we may get a very imperfect result. Do we have all the tools related to what I just said? All the tools doesn't just mean equipment, and we need to make sure that we have the equipment necessary in-house. It can happen that you start a procedure, in my setting that happens unfortunately, and I find out middle of the case that I don't have a certain cutting balloon, a Wolverine of a certain size that I need, or something like this. So it's important that we know ahead of time before we begin a case that we have all the tools. But the necessary tools are also related to skill and expertise. So I need to make sure that I can deal, I'm competent, and that I have the skills and expertise to deal with the most complex situation that I'm undertaking. So in general, I use a planned two-stent technique with large important side branches in true bifurcations, when the side branch is considered difficult to recross, when we have a complex left main, true bifurcation. My preference is DK crush. Occasionally culotte. In left mains, I tend not to use culotte because of the possibility of a napkin ring in the distal left main if you don't have cells that are large enough to take that particular left main diameter. TAB occasionally even procedure like SKS. You have to be flexible, I think. Do it well, whatever you do. Let me show you a case and a half a case if we have time. This was a case of an 84, and it's too bad because the previous talk that would have been here would have dealt with this, so at least we're going to have a couple of cases on it. 84-year-old female admitted with an NSTEMI to a Northern Ontario hospital. Northern Ontario is the province I live in Canada. For those of you who haven't been there, which is I'm sure the majority, it's a large province by territory. This city where this hospital is a 17-hour drive from Toronto, or 2.5-hour plane ride for the patient who is transferred from the hospital. That's 2.5 hours by plane. So she, with her NSTEMI, underwent angiography. She had high-risk features, so not a surgical candidate. Found to have severe calcific three-vessel disease, CTO of the RCA, collaterals from LAD septals, good LV function. She was transferred, and this is what we're looking at. So they had already attempted a PCI. They had attempted to open her LAD and were able to wire it, but couldn't cross that mid-distal transition of the LAD with any balloon that they had. So they referred her to us for high-risk rotablation, even though I had proctored them a few months before on rotablation. But this was still, it's not a surgical center, so its surgery is 2 hours by plane away. So very appropriately, they referred to us, and I think I tried one little try with the 1.5 balloon, found exactly the same thing, so immediately switched my guide wire to a rotowire. 1.5 burr, and this is a result that we had afterwards. As you can see, after modification, the NC balloon actually expanded very nicely. We then optimized the entire proximal segment to where we needed to, and we had a decent result. We then deployed 2 stents, one in the distal segment, one in the proximal segment, overlapping, as you can see, and had a very nice result in the LAD at this point. So now what do you do with this circ bifurcation? It really is a 001, so obviously an osteal circumflex with also very diseased OM. I now wired the OM, and that was difficult. Actually, I initially entered the dissection plane. I'm not showing that, but eventually was able to get into the true lumen of the vessel to protect that branch. With great difficulty, advanced a 1.5 balloon with lots of support, and was then able to dilate this vessel with a 1.5. Never considered that this would be large enough for a stent. So then optimized the circumflex, the side branch again now with a 2.0 balloon, and then went to stent the proximal circumflex where there was a bifurcation, I thought a good landing zone, into the left main. Now my stent, if you recall, in the LAD did not go to the bifurcation. So I did not want to do left main bifurcation in this case because I didn't think that was necessary. So we then do a pot with a 4.0 NC balloon based on IV assessment. We knew that it was about a 4.0 vessel. As you can see, the side branch remained patent very nicely. We then recrossed a distal cell recross into the LAD, a 3.015 NC balloon in both vessels. Initially did a moderate pressure inflation because of course there's no stent at the ostium of the LAD. Then redilated the ostium of the circumflex, and finally a kissing balloon inflation, giving us a very nice result. And a nice IVUS result both at the ostium of the LAD, no evidence of a dissection, and good result in the distal left main. You see the second wire there, the circumflex wire. One other quick case, this is just a summary of a case. Again, an osteal lesion in a very large diagonal, clearly 10% of LV subtended here. And I was doing this as a live case a few years ago in a radial meeting, and as you can see, it's a radial case. And my first intention was actually to do a 2-stent procedure, and one of the panelists, Olivier, not Olivier, but one of the French originators of the radial techniques, actually said, no, wait, why don't you just do a crossover into the LAD? So we did that and worked very beautifully and with a very nice final result. So consider all the options in these, especially osteal lesions. There's this very small dissection, which I didn't think was significant, and the patient did very well, seen by OCT. So I think we'll end there. Be flexible, have all the skills, have all the equipment necessary, and consider all your options. Thank you very much, and welcome any questions, discussion.